It's my pleasure to be together with you today for that webinar from GREM. GREM is our new journal, means Gynecological and Reproductive Endocrinology and Metabolism. And we have taken the habit to have a discussion with our authors in the next issue we select two authors to discuss their presentation. Today is the author that we have invited is Professor Svetlana Vujovic. Professor Svetlana Vujovic is the head of the Department of Gynecological Endocrinology in the Clinic of Endocrinology, Diabetes and Diseases and Metabolism of the University Clinical Center of Serbia in Belgrade. She is very well recognized. Not only she's a member of the Gynecological Endocrinology International Society Board, she's a past member of the boards of the International Menopause Society and the European Menopause Society, and she's also actually the president of the Serbian Menopause Society and Endocrinology on Gender, and founder of the Belgrade Gender Team. This is a topic very interesting, and once again we will ask Professor Vujovic to speak with us in another, not today, but in another time about what your activity for gender studies. But today our goal will be the discussion of that beautiful paper, which is a case report. It's a case report. And the paper, which is signed by Svetlana Dragocevic-Dikic, Miladenko Vasilievich, Alexander Jurisic, Ljubomir Zrbinovic, and Svetlana Vujovic. I'm sorry for the bad pronunciation, but I'm not so a master in Slavic languages. And the paper is on resumption of ovarian function and successful pregnancy in a patient with premature ovarian insufficiency after a long-term hormone replacement therapy. It's a beautiful topic that I mentioned when we discussed it in the previous webinar. And then I would like to give to Svetlana the microphone, and we will have the pleasure to hear and to follow your presentation. Thank you for being with us. Thank you, Svetlana.
First of all, good afternoon. I would like to thank Professor Giannazzani for great job for creating these webinars and giving us all science and new nice ideas. Today, I will talk instead of my colleague. She's not able, but this lecture will be a gift to all women all around the world. All of us know that follicular dynamics is changed during women's life. During 20th week of pregnancy, there are 7 million of follicles, and later on they are decreasing during our lives. But in some group of women, there are lower levels, lower numbers of follicles due to maybe decreased number of primordial follicles or increased atresia or altered follicular maturation. And when one woman has such a problem, she stopped menstruating, or she has maybe oligomenorrhea and she's younger than 40 years of age, she came to the doctor and then diagnosed as premature ovarian insufficiency. It is oligo or amenorrhea in women younger than 40 years of age. And during a previous period, we defined it as FSH over 40 and estradiol below 50. But according to the last ASHRAE's definition, FSH over 25 will be defined as POI. Why? Because it's very important to make diagnosis on time, because many of them would like to be fertile, would like to have pregnancies in the future. And then all that women with this diagnosis are shocked. What's going on? Many doctors tell them, you have no time to have baby, and everything is diminished, your reserve is down, and they're so disappointed and they're sad. And is it really a truth? Or maybe we can do something and create this small balloon in the sky to help them for being mothers. So now we'll give one case presentation and we'll talk after that about all of these things. In our center in Belgrade, we have a database on 2,000 POI patients, and this case presentation is really a very rare one. Just 2.2 percentages of 2,000 women can have something like this one, and they're all others receiving pregnancy on some other way. But it is a 21 years old woman with height 168 and normal weight. And 2 years before, she had spontaneous pregnancy and delivery of healthy male singleton. Then, after that, she had secondary amenorrhea, had flushes at admission of the hospital, and premature ovarian insufficiency was diagnosed according to this FSH, LH, estradiol, and anti-Müllerian hormone levels. After that, she was treated with estradiol valerate and norgestrel for 5 years. And then, after that period, with estradiol valerate and norethisterone acetate for 8 years. So altogether, 13 years, she received pregnancy. Melatonin was added at last year of pregnancy. After 8 years, FSH and LH decrease, and then she had her self-initiative to stop therapy. Why? We don't know, but she decided it. And 1 month after withdrawal of therapy, all of us was shocked with her FSH and LH. They were in the normal range. So it was resumption of ovarian function, and it was diagnosed and detected. And we asked ourselves, how long will it last in the future? 18 months later, she has amenorrhea once again, and we discovered spontaneous pregnancy. After that, it was a normal terminated pregnancy, and a healthy baby girl was born by cesarean section, and it was a baby during pregnancy. So something very unusual and not very often, but possible. So what are the causes of POI? We can divide them in primary and secondary, and primary are due to chromosome abnormalities, FSH receptor gene polymorphism, inhibin B mutations, enzyme deficiencies, autoimmune diseases. Secondary are due to chemotherapy, radiotherapy, bilateral oophorectomy, uterine artery embolization, and various infections. And then when whoever of these women detect anti-Müllerian hormone, and of course it is low, they was shocked. It is disaster when they know that anti-Müllerian hormone is low, but we have to look at this situation that anti-Müllerian hormone is gonadotrophin independent, and it indicates something what will be later in the life, but FSH dependence is very important for other follicles remaining in their ovaries. When women like this with POI has amenorrhea for 1 year, they have 1,000 preserved follicles. So we have to fight for them, for helping them to grow, and for that woman for maybe being pregnant. So what we need for the diagnosis of POI? Hormones like FSH, LH, estradiol, anti-Müllerian hormone, but in our center, we detect as well inhibin B, prolactin, cortisol, testosterone, DHEAS, FT4, TSH, because there are some other endocrinopathies which can be comorbidities with POI. Autoimmune screening is necessary, and karyotypization is necessary for younger than 30 years of age, as well pelvic and breast ultrasound. So ovarian biopsy is doing only for research, and in some women, if we are interested in it, and dual X absorptiometry is optional later on in their lives. So are there any changes between ethnic groups in some parts of this planet? We made one study, international study with China and Great Britain, and there are some gene changes, but there are just a few of them, and many genes can be involved in etiology of POI. As well, we were interested in stressful situations, and in one group of 800 women, we have found that 50% had stressors before initiating of POI, and that's very important that stressors can be initiated through all systems of their bodies. As well, sleeping habits. If women are going to the bed after midnight, these rhythms of sleep and daytime will be disturbed, and it can influence all gonadal axes and ovarian content. So in therapy, we have to initiate estradiol in the first place, and this therapy is very, very important because estradiol sensitizes and differentiates granulosa cells. Then it down-regulates FSH and LH receptors, increases response of FSH and number of LH receptors previously induced by FSH. It lowers LH and prevents premature luteinizing of the remaining follicles. And in some studies, during 12 months, it is 46% of patients ovulating at least once. So it's not impossible story. As well, estradiol stimulates endometrial proliferation and production of the cervical mucus. So why is FSH lowering so important in this story? Because as much as it is high, it is ineffective in stimulating folliculogenesis and possibly ameliorate the regulation or desensitization of diminished FSH receptor. So we can do it by estradiol. And releasing of the few FSH receptors may diminish the autoimmune processes in some of them. Estradiol improves vascularization and endometrium flow. So we are talking as well about endometrial receptivity by genomic pathway and non-genomic pathway. And estradiol receptor alpha promotes mitogenic activity and proliferation. So we have to know all of that because we have to put them on appropriate therapy before being pregnant with appropriate dosages with estradiol. So what are suggested dosages? For estrogens, it's twice as high as recommended dose for hormone replacement therapy in the menopausal women. It can be on transdermal way or CAE or 17-beta estradiol orally. And in our group, we prefer 17-beta estradiol orally in all POI patients. And with adding progestogens, in our group, it's micronized progesterone for 2 weeks in the luteal phase. And what about fertility rate? Please don't say at any time to any patient, it's impossible to be pregnant if they have ovaries, because we don't know what can be real in the future if we give them enough amount of estradiol, progesterone, and some other hormones. And other way of being pregnant for them are donor oocyte or embryo freezing, freezing of mature eggs, cryopreservation, tissue transplantation, etc. So the first line of therapy are estroprogestogens. What's about duration of this therapy? According to the latest information, no limits during life, but dosages are once again very important. For ovulation induction in such a patient, we have to increase estrogen dosages for a certain part of time, not whole life, but for a few months, let's say 3 or 6 months, in order to achieve FSH 10 to 15. And in this group of women, it's not a contraception. Opposite, it's a way for being pregnant. So natural or modified cycles with estrogen represent first-line therapy for being pregnant, and low-dose human chorionic gonadotropins in the first cycle days can be added, but in the first grade of POI, meaning POI with FSH 15 to 20, not if it is over 40. A year after last menstruation, there are these 1,000 follicles remain, and 75% of women with POI have potentially functional Graafian follicles remaining in ovaries. Very often they have inappropriate follicular luteinization, which prevents ovulation. And other studies made by Van Kesteren and Schumacher, who found 3 out of 4 women who have ovarian follicle remaining. Karopok found pregnancy in women 4 years in POI, Guangzhou pregnancy in women after 10 years of amenorrhea, but treated with estrogen. So what will be time for oxygenation? When we increase estradiol valorate to reach second day FSH between 10 and 15, and utrogestan or micronized progesterone, and no dominant follicle with quality oocyte during 6 months with FSH, which is normal, then they can be maybe candidates for oxygenation. In the meantime, we are preparing endometrium for such a thing. As well, we can add melatonin because receptors for melatonin are on theca cells, and it increases percentages of pregnancy, and it inhibits GnRH, low response to LH, and there are many other of melatonin responses. Then, if DHES is low, we can add it in a few group of women with low DHEA because it's converted to estradiol, which suppress FSH in addition. An increase of production of testosterone by very early follicles. And in this study, we can see that DHA supplementation can induce increase of ovarian reserve and oocyte yields. So we have to add all hormones which are not in enough amounts present in that women. Other therapeutical modalities are prednisone, plasmapheresis, pentoxifillin, tocopherol, etc. But what's about the implantation rate? So we can have embryo from that women, and then we have to think about the implantation rate. Endometrium has to be with a good weight, but of course inside endometrium hormones are very important: growth factors, cytokines, adhesion molecules, and all other hormones. So endometrium receptivity for embryo will be another task, very important for a situation when we have embryo in POI patients, but we want pregnancy as well. Insulin is one of the remarkable hormones for implantation rate because in many women, we don't know about hyperinsulinemia, and hyperinsulinemia is something what can be a cause of pregnancy loss or pregnancy failure, because insulin resistance syndrome leads to thrombophilia, endothelial dysfunction, oxidative stress, etc. And women must have a normal weight because adipocytes, as endocrine cells, exhibit increased secretion of pro-inflammatory adipokines and reject embryos from the endometrium. Integrins are the best marker of endometrium receptivity, and in the luteal phase, it's very important that a failure to express alpha and beta 3 integrin can be present, and progesterone supplementation expresses them and help for the first stages of pregnancy. What's about glycodalin? Hyperinsulinism decreases glycodelin, which is apoptotic, antiproliferative, and it's very important for growth of endometrium and for exception of pregnancy. So before being pregnant, all these women must reach FSH 10 to 15, TSH in normal range. We have to improve their insulin sensitivity. Endometriosis has to be treated if they have it, and thrombophilia status must be corrected. And if not, endometrial stem cells transplantation can be done when the human endometrial stem cells exhibit stem progenitor cells properties, and we can do this, but in conclusion, mesenchymal stem cells properties and in vivo survival of human endometrial stem cells make them ideal seed for stem cell transplantation in the treatment of POI. But when can we do it in big centers after doing all these previous things, not to go at the first step on endometrial stem cells transplantation? And then adult ovaries possess rare number of ogonial stem cells that can stably proliferate for months and produce mature oocytes in vitro. So injection of labels of OCS into mouse ovaries leads to differentiation of these cells into mature oocytes, and they can be fertilized. What about all young women who had cancers on some part of their bodies? Ovarian transposition is as well some possibilities of being pregnant later in the life, whenever they have pelvic irradiation in malignancies or permanent ovarian damage. And meta-analysis of 24 articles on 892 women came to conclusion that ovarian transposition is associated with significant preservation of ovarian function. So it is just for women with malignancies. When we are talking about these POI patients, we have to talk with empathy, with sensibility, not on discouraging way and talking them, it's impossible to be pregnant, please go away because you are too old, you have no mature eggs. But we have to help them, we have to understand them, and we have to add all hormones during at least 6 months and looking out what's going on. Are there follicles? Are there growing follicles? And if not, then we have to try all other modalities. But for oocyte donation, it's necessary to prepare endometrium because we'll have a higher pregnancy rate if we prepare it appropriately and on time. And for the end of this story, it's a long story and we can have many answers, and I'll try to give questions. I'm sending you this nice fresco, White Angel, from our Serbian monastery from 13th century, nearly the same times with Italian Renaissance. And the art will save this planet, and the medicine and the science, and all of we like it. So we have to look at nice things and to look in the future with more courage. We have to be encouraged and to create a new nice future with science and the art. Thank you, Professor Giannazzani, and all of you colleagues who are hearing for this and are waiting for questions. Thank you very much.
Thank you, Svetlana. Thank you very much for that beautiful presentation, because this outline how we have to dedicate more attention to the real biological situation of our patients, and how you are completely right, how our position have to remain full of possibilities for our patients. They have natural possibilities, the possibility that medicine can now help, but we have received a series of questions, and I would like to go all of them and to try to make even more attractive and more important from educational point this kind of webinar. First of all, I would like to thank our friends from Mexico, Hector Rogelio Santana Garcia, and from Kiev, Natalia Pedachenko, send all her regards to you, Svetlana, and to all the
Best wishes.
And okay, then now for a question, I would like to start with that one that I found very interesting. It's in many countries, diagnosis of POI is confirmed according to serum concentration of FSH and estradiol. Next suggestion for women looking for pregnancy is to accept a donor oocyte. Is it sufficient for the diagnosis?
Very often it's not sufficient because sometimes there are other endocrinopathies which will really influence FSH and LH. When some kinds of subclinical hypo or hyperthyroidism is present, FSH and LH can be different. Or in the autoimmune causes of POI, we can have changes in adrenal glands and other glands as well. We suggest that all centers do OGTT, oral glucose tolerance test, because hyperinsulinism can influence all these processes. And it's very important that we know how to interpret this area under the curves for insulin in OGTT. And very soon we'll have a conclusion about that interpretation. When to add metformin and other things, other medications, and we have to cover all other hormone deficiencies before oocyte donation, because it will not be successful.
Thank you. Now we have a question raised from Apostolos Kampagiannis, who is also linked to the previous webinar that we have about POI. He asked why you have not done karyotype analysis in that patient. But I'd like to tell him this patient became pregnant and she had a normal pregnancy and a normal delivery. And then this completely cut all the problems that we have discussed when we were speaking about other kind of premature ovarian insufficiency, mostly in early adolescent girl. And then I would like to go to the next question. And the next question is, what is the optimal time for endometrium preparation for the conception? After, because you mentioned that one, after decreasing FSH to 10-15, in which period shall we expect remaining oocyte growth?
We are following up FSH, LH, and estradiol 1 monthly on day 2 or 3 in all following cycles. So we add estradiol as much as it is needed. Sometimes it is, let's say, 12 milligrams of estradiol valerate, and we added as well micronized progesterone in another phase of the cycles. And then depending of this FSH, LH and estradiol, we increasing dosages of estradiol.
Yes.
And no one of patients have any contraindications with these higher dosages for a short period of time, let's say during 6 months. Some of them may be for a longer period, because we do tests for thrombophilia as well. And whenever it's necessary, we add folic acid and sometimes aspirin or whatever other is necessary for changing endometrium environment.
Thank you. Then now I would like to, Sulin Hamed. We have received several questions from her, and no, from him. And the first question is related to a patient that is a 38-year-old lady, which she has been trying to conceive her second child for at least 5 years. She had already 1 child, but she had also endometriosis, and she had also a single ovary, because one was taken out for a dermoid kyst 9 years ago. She was experiencing perimenopausal symptoms, but still menstruate regularly every 25-27 days. Would she benefit from hormone replacement therapy to achieve pregnancy? This is this question. And he mentioned that she have also an endometrioma of 3 centimeters in the remaining ovary, and then she have tried 3 IVF, but who led to blastocysts, but all of them failed to implant. What it should be your suggestion?
It is a very interesting story because once again, I would like to repeat, we have many, many patients. So I'm talking about great clinical experience. Women with endometriosis has a problem because it is a whole life present disease. So it's not just a disease when we see one great cyst or endometrioma, because until now we know for 56 antigens which prevent implantation in endometriosis if we put it being in a normal ovarian secretion of that woman. So we have to give them some kinds of contraceptives, like, let's say, some of them with drospirenone, sometimes continuously without menstruation for 3 or 4 cycles, for decreasing antigens in endometrium. And after that period, we can add estradiol as much as it is needed to increase some of them oocytes which remain. So first of all, we'll suggest some kind of contraceptives, and not estradiol valorate and micronized progesterone, to decrease values of endometrioma and decrease antigens. And after that, in 1 cycle or 2, we'll try to increase remaining oocytes. The most important is to improve endometrium to be in a situation to add that embryos.
Thank you. Then now Apostolos Kampagiannis, he asked something about that patient that you were referring the data. He asked, could we also have a personal opinion for the reason of the resumption of ovarian function? And what actually happened? And how is this woman now? Is she still POI?
No, she is not anymore POI. And we was really impressed because we have only 3 women like this one being having another babies, but some of them were traveling from one continent to another, meaning they lived for a while in America and came back to Serbia. And after that, they have ovarian resumption. So who knows what else happened in their brains. There are many, many things we can't explain at any time. So they are really rare cases, but they exist. For me, more important are those where we can induce pregnancy with therapy and when stressful events are not always a case.
And then Natalia Pedashenko, she, dear Svetlana, thank you. For how long do you prescribe twice dose of HRT in infertile women with diminished ovarian reserve, then with an FSH around 15 and not with POI?
Other women, I mean menopausal women, have a natural, normal dosages, what we know. I mean, we've been over 50 years of age. But if they are POI and if they are not interested in pregnancy rate, then we are adding them this therapy until age is about 50 years of age. But we are following up their values of FSH, LH, and estradiol. And depending on that, we change dosages if it's necessary before.
Thank you. And then I would like to make Ihmat Nahumi make a comment. Can patients with POI get pregnancy while continuing on HRT? Yes, certainly, yes. This is the possibility. And we mentioned also in the previous webinar with Alessandro Genazzani that if the woman, they don't want for any reason, any pregnancy, we have not to give HRT, but we have to give a contraceptive treatment. Do you have the same vision, Svetlana?
Completely. Yes, this is not contraception. It is induction of ovulation treatment. Just the question is how many, what are dosages of estradiol? That's important.
Thank you.
Because we are changing endocrine milieu in ovaries and in the endometrium. That's very important.
Yes. And then we have also another question from Oltea Ionescu. She asks, what is the daily dose of progesterone that you recommend during a pregnancy obtained in a woman with POI?
Mostly it's 3 times 200 micrograms of natural progesterone. And if it's necessary, with add progesterone injections every 3 or 5 days during first trimester, if it's necessary. But we measure hormones during pregnancy as well, and then make that ratio between estradiol and progesterone. It's very important to continue with estradiol therapy and progestogen as well during first 3 months of therapy, maybe
Yes.
a little bit longer.
Yes, I totally agree with you. Maybe a little bit longer. And then we have also Professor Xianzhan Ruan. She is with us, and I am very happy about that. And she asked, dear Svetlana, thanks for your excellent lecture. And how about the effect of taking DHEA for POI?
Whenever there are lower concentrations of DHEA, meaning for us lower than the middle of that natural concentrations from the laboratory values, then we add it. But it's not a rule for all women, because one group of them have a normal DHEA, and then if we add it, we'll have some contraindications like acne or hirsutism or whatever else. So we have to check DHES, and then we change dosages. But if it's lower, we add it as much as it is needed.
Yes, I also agree with you. We also check always DHEA sulfate to be sure that she have reduced concentration. And then now it's always on the dosage. It's a question from Andre Rothman. Wonderful presentation. Greetings from Frankfurt. I work with bioidentical HRT. So which dose would you recommend? And I think cyclic, 114 day, and then 1528. What dosage do you recommend?
When we are talking about bioidentical hormones, our group was giving that therapy for some 25 or 30 years because it was started in France. We know about that. And we give them very often whenever patients would like to. But then it is estradiol, bioidentical, and the dosages depends of FSH-LH estradiol. Very often we give them twice daily, in the morning, in the evening, because women don't like to take it 3 times a daily because of the application they're working, and it's not always possible to put it, but in the morning and evening, and then twice, very often in the morning and twice in the evening for many of them, or maybe more. So it depends of FSH and estradiol. It's not fixed dosages, as well as progesterone in gels, etc. As well, we make dosages according to their values.
Okay.
So it's individual.
Then is a question from Ahmed Galal of the possible use of aromatase inhibitors in ovulation induction. I would like to, what is your advice on that point?
We have no advantages of aromatase inhibitor in comparison with estradiol and all these other hormones. So very often we have a group of colleagues trying with maybe FSH and LH ampules, giving over dosages, but it is as well no success. So please don't do it. Only make changes with estradiol and not with high dosages of FSH and LH ampules.
Thank you. And still Apostolos Kampagianis is asking us about the problems in the pregnancies of individuals with POI. When you already achieve a natural pregnancy, did you have any problem with MOL for gestational age or intrauterine growth retardation or preterm labor?
We have no complications, and that means impossible, because always we have some kind of complications. But why is that so? Because we make complete testing of all these women with many parameters. I have no enough time to explain a whole protocol, but all of them can be pregnant when they have ideal BMI, body mass index, then when they have no untreated diabetes or other diseases. So we prepare them for the pregnancy, and then we tell them, and now please try to conceive, let's do it. So if they are governed by such a way, they have no complications. Later on, they have 1 monthly checking in our departments, and we are looking for fetal growth and all other parameters, and then there are no any complications. Some of them who had problems are one group which are impatient. I want to be pregnant as soon as possible.
Yes.
No, when there is impatience present, then something will be wrong. They have to be relaxed. So we add sometimes some kind of sedatives or other relaxing agents, just to understand that they have all time of their lives. Not you have only 2 months, 3 months for being pregnant. No, they have POI. So we have to emphasize on relaxing, have time, and we will reach pregnancy just with such a situation.
Yes, concerning this activity, Tetiana Tulchenko is asking you something. If you have younger patient and that they have irregular cycle, and then you check and then have high FSH and low anti-Mullerian hormone, do you have to speak with these patients about the possibility that they develop a POI, and then what kind to do?
We always speak with our patient and spend a lot of time on that speaking and understanding. So believe you or not, I am speaking individually with many of them, and they're even traveling from Australia to Belgrade because of speaking, because they want that someone understand them and to give them support. It's very important,
Yes,
psychological support. And there are 4 stages of POI. In the first stage, FSH is higher, but estradiol is still preserved in some amounts, but there is no ovulation. Then we add only progesterone in the second phase, and everything's all right. Some of them very slowly are going to classical POI with FSH over 40, maybe 2 years, 3 years, 5 years. So it's a long period. And then when estradiol is decreasing, then we are thinking about other possibilities. Some of them want to preserve their oocytes, and we are talking about such a situation if they have no partners, because there are some serious times when you can't have a male partner because of COVID or anything else, but they can preserve their oocytes. So we are working with them as well and follow them very often. My team is a great, nice team, great team, and Natalia Pedachenko know them, so they are enthusiastic and like to speak with patients, and that's very important, like Natalia's team, and she has as well a great knowledge about that part of medicine.
Thank you. And then we have a question from Manju Navani, and she's mentioning the patient, the association of autoimmune thyroid autoantibodies production and the association with POI. What did you believe it should be the role of anti-thyroid immunity in the development of POI?
Antithyroid antibodies are just one group of many other antibodies which we can see in the endometrium as well. But what is the most important, that TSH, thyroid stimulating hormone, will be from 1 to 2.5 at least 6 months before pregnancy. So we are checking it 1 monthly, 6 months before pregnancy, and don't don't put embryo in the endometrium before that time, because we know it will be rejected in such a situation. And sometimes we add a corticotherapy, but for a short period, if somebody has a very high level of antibodies. But that level of antibodies are in correlation with the way of life, with sleeping habits, with stressors, with many other situations. So we have to think about whole women's life, and we have to change it.
Fantastic. Now I have an interesting case report from Xianjiang, Ruan. She is right to you. Dear Andrea and Svetlana, just now we have a 29 years cervical cancer patients after 7 cycles of chemotherapy. The last time, 3 weeks ago, before local radiotherapy, she visited me for ovarian tissue cryopreservation, but the FSH was more than 100 units and the anti-mullerian less than 0.01. We discussed it a lot. Then we decided to help her. After removed part of her ovarian tissue, we surprised to find her ovarian tissue containing high density primordial follicle. How to explain?
High density, she has high density
Primordial follicles.
As far as I understand, they took her ovarian tissue before all these radiotherapy and everything.
Before radiotherapy,
Mm-hmm.
But already the FSH level was very high and anti-mullerian low.
Mm-hmm. I understand. So it's one thing more for the conclusion that there can be in the ovaries preserved some of such follicles. Not all follicles respond on the same way. So it encourages us to understand that when we have a normal hormonal milieu later on, such follicles can grow. So they are not all in the same stage of development, and some of them can be completely normal. So that's really a conclusion for such a situation.
Thank you. And then now Manju Navani, which have already put several questions, that one about hypothyroid autoimmunity. She's now asking what is the importance to check also about the bone quality and the bone condition when we have to suggest a treatment in a POY patients?
We do osteodensitometry in all POI patients who are not looking for pregnancy, because we have a small radiation, but it is radiation during this procedure. But in all others, we are looking for the bone mass density and bone mineral density. And the first line therapy are estroprogestogens, not bisphosphonates, not other kind of treatment, because estrogens preserve bone, and we have better T-score and Z-score after a few years following up such a woman with good dosages of estradiol, even better than at the beginning of the following up. So the first line therapy is estroprogestogens, and as well vitamin D, of course, calcium, but they are all additional factors.
Thank you very much. And then an unknown participant, he asked, concerning on insulin levels that you mentioned, is detecting of basal glucose and insulin, detecting HOMA index sufficient for understanding of endometrium endocrinology?
This HOMA index is not special enough. It's not so sensitive, because we are interested in that's what's going on during some stimulations. When we are performing oral glucose tolerance test, we know in fact what's going on during eating cakes, or if someone is under stressful condition, because cortisol is inducing insulin, is increasing insulin as well. So when we look at that curve, we can find out hyperinsulinism, not diabetes, not insulin resistance, only hyperinsulinism, which is enough for stopping glycodaling normal values and rejection pregnancies. So it will be our suggestion to do in all women OGTT and to understand on a special and a new way how can we explain that curves, because it's not diabetes. And from the normal curve, we can see the next step, hyperinsulinism, then insulin resistance, and then diabetes if we do nothing. And then when we add, let's say, metformin for some patients with hyperinsulinism, even during pregnancy, nobody will gain more than 10 or 12 kilos during pregnancy. So there's no diabetes during pregnancy and eclampsia and many other things. So we have to do prevention of diabetes and all complications of pregnancies.
Thank you very much. And then now another, from an anonymous, another very important question, which is a general one. How many years can we treat women with POI? And what about breast cancer risk?
In our group of POI patients, 2,000 women, we have nobody with breast cancer until now. And we are working with that group in the last 15 or 20 years. But sharp increase were detected in 1999 during bombing of Belgrade. Why, we'll see later on, etc. But no breast cancers. And why? Because we are looking for estradiol and progesterone in women with benign breast diseases. And if they have cysts or fibroadenomas during therapy, we change dosages of estradiol and progesterone, and cysts can disappear. So we are treating cysts as the group of Natalia Pedachenko's as well, because breast diseases must be treated before any other periods. Latest study from Oxford, from Jason Carroll, shown us that menopausal women with low estradiol and high insulin have higher incidence of breast cancer. So it is very important to decrease insulin levels on time and to add appropriate estradiol values. And there are no breast cancers in such a persons. So we have to take care about that, as well as we are talking about thrombosis. We are giving natural estradiol and progesterone and checking out thrombophilic status and giving them therapy. So prevention and testing before must be more completed than only FSH-LH estradiol. I know it's cheap, but it's not enough.
Yes, but I would like to ask you something. And going on with the agent, with the treatment of the patient, do you believe that oral treatment or transdermal therapies too can add a further benefit, mostly for estrogen?
Yes, because that patients continue with the therapy when they are over 50, over 60 years of age, but we reduce dosages, of course. And even I have now one patient of 95 years of age, and she took hormone therapy from the period when she was 38. And she was a patient that from my professor, and I followed her further. And what's going on? She used estradiol by gel and progestogel just once daily, but it's enough with low dosages of metformin. And she's university professor with perfect health. So we have to understand that.
Thank you very much. Thank you very much. This is the message. Please, to the public, you have to remind that overweight makes diseases. overweight and obesity. We have to fight against that one. We have not to close our eyes. We have to speak with the woman. They have to move. They have to walk. They have to try to make a selection of their food. And in the meantime, as Professor Vujovic was telling you, she has to maintain also her estrogen, RDH, her androgens too. These are part of the femininity, part of the daily life. How we were thinking, how we can believe that the hormones who make the femininity, who protect the woman during pregnancy, they can be considered harmful. This is not true. We have to take care of that. Svetlana, I think it was a beautiful day. We have presented a beautiful case. We are happy for her that she has selected you as her clinician. And on behalf of all GRAM public, I would like to thank you to have published your case report in our beautiful journal. And we wish for all of our participants that we can continue to be together. We have not yet ready the issue of March, and we will select the next speaker for the next interesting paper presentation. Then thank you to the Belgrade staff. Thank you to Professor Svetlana Vujovic, and thank to all of you who were with us today. And still, I remind you that Gynecological Endocrinology Society is hardly working. We are preparing our next Congress for 2022 in a COVID-19 free world. Thank you, thank you, thank you.
Thank you, thank you. Bye.